BBC Sounds. Music, radio, podcasts.
Hello. Coming up in the next half hour, yet another use for aspirin. I interview the researcher behind a new study that suggests it could treat cancer and preeclampsia. If you've ever had a baby, you will have been screened for the condition. But how much do you actually know about it?
So when my wife was pregnant, and she's married to an obstetrician, she said, "What's this preeclampsia thing?" And I sat there and thought, well, if she doesn't know, then what hope is there for anybody else?
More about preeclampsia later. But first, the digitisation of the NHS, which will, among other things, transform the way that patients interact with their GP. Being able to Skype your doctor from your phone or computer seems to be the most widely promoted example of the sort of change we can all expect. But do video consultations live up to the hype? Dr. Margaret McCartney is in our Glasgow studio. Margaret, how much research has been done in this area?
Well, not nearly enough. There certainly has been some research done over the last few years looking at the pros and the cons of video consultation, and I think it's fair to say that there are more questions than answers at the moment.
What sort of cons are there?
Well, there's lots. So the advantages that seem to be touted are things like it'll be more efficient, it'll be more accurate, allows doctors to spread their workload more evenly. It might allow patients to keep continuity of care with doctors, less travel time, don't have to get in quite so often. That's the kind of things people are saying. There's a really great study that was published in the Journal of Medical and Internet Research in 2018, and they looked at the rollout of 3 clinics trying to do more video consultations. And they found in antenatal care, they just couldn't roll it out at all. It was just too difficult to do. It wasn't popular with their patients or with their doctors. And they found huge problems actually in just rolling out the technology itself. And they really found that doctors were having to sort of fix technological difficulties that really hadn't been properly funded or accounted for.
So would it be fair to say that the research doesn't back what we're hearing in the media about this as being this new revolution that's going to impact on the NHS?
The research definitely does not back the idea that this is going to be something huge and new that is actually going to work for people. Now, it might work for some people some of the time. We shouldn't write it off. But I think we should be very careful of making big claims that simply can't be held up with the evidence for it. But I think the problem that we have is that it's being hyped beyond all reason just now. And unless we're really careful and look at the pros and the cons, we're in danger of doing far more harm than good.
Thank you, Margaret. Well, video consultations may be grabbing the headlines, but a growing number of GP surgeries are opting for another way to boost their offering. Online consultations that enable patients to send in their query or concern on any day at any time, and their GP will get back to them, typically the same or next day, with an answer, which may be anything from a prescription or booking a test to an appointment for a telephone or face-to-face consultation. Well over 1,000 practices already offer online consultations, and their ranks are swelling by the day. Around 20 companies offer different IT packages, but eConsult is one that's widely used. London GP Murray Ellender helped found it.
Like all GPs, we were really struggling with demand and the need to manage lots and lots of patients coming through the door. And we knew that there was some solution in digital and wanted to explore different ways of patients interacting with us. And we looked at various options. So we looked at things like video as a way to consult, but actually video works for some patients but doesn't save a lot of time. Still need 10 minutes of a doctor, 10 minutes of a patient. So we came up with a different idea, which is gather the history in the patient's time, push it through to the practice, through to the GP who knows the patient has the record, and then let the GP make the decision about what to do.
So what does this allow patients to do now if their practice is using it that they couldn't have done before?
So I guess it allows them to contact their GP anytime, day or night. It gives patients access to their own GP when they need it. So I think because of the increasing demands, we've now have a system where patients have to battle through on the phone at 8 o'clock in the morning in order to secure a face-to-face appointment. Whereas we know that actually not everything has to be handled with a face-to-face appointment. There's a lot that comes into general practice into the consulting room that could be handled without you necessarily having to come in. So if we can gather that information up and push it through to the GP can then make a decision about what to do.
Hello, St Stephen's Health Centre, can I help you? Would you be able to come here?
My name is Balvinder, practice manager at St Stephen's. The complaints and grumbles we were getting were generally around our telephone system, and we employed more receptionists, and all that seemed to do was drive up demand
So what sort of grumbles were you getting?
That the phone wasn't answered quickly enough. You know, if a receptionist is triaging a patient and trying to get some basic clinical information, that takes some time.
People got fed up with being on hold.
People want immediate access. They don't want to be kept holding and listening to music. And
so you knew you had to do something.
We had to try something different to improve patient access.
My name is Rachel Bauer. I'm a GP partner here, have been since 2004. As for many GP surgeries, we have not as many GPs as we would like. We face a recruitment and retention crisis, difficult to recruit salaried GPs in particular. So we're probably about down by 25% on the amount of GP capacity we would like.
So in practice, that means it's difficult to get in to see a doctor, and when you do, there are long waits.
Yes, I mean, we do make sure that we are able to offer emergency appointments when clinically necessary, but we're still sometimes struggling with on-the-day demand.
St Stephen's Health Centre in Tower Hamlets, East London, is a typical busy inner-city practice. It's been using online consultations since 2013. So, how does their current system work?
The route in for patients is via the practice website. Most practice websites tend to be a picture of the practice and a phone number.
We've got a typical one here on your laptop. So like many practices, my practice website has a picture of the surgery, a telephone number, and other links, all very useful, of course.
So what we do with practices is say, look, make the offer to consult online really prominent. So here's the one for St Stephen's Health Centre. And you can see it's got the NHS logo. It tells you you're still on the practice website, but actually very prominently it says, contact our doctors online.
So you've got 3 big orange blocks here. Explain what they are.
So here we give patients the option to, they may need help for a specific condition. So I know I've got back pain, or I think I might have a urinary tract infection. We've got another one for, actually I've got a series of symptoms, I'm not quite sure what's wrong. Or we've also got a section for administrative queries. So I need a letter, or I need a repeat of a fit note, that kind of thing.
Going back to your back pain example, I've got back pain, I've clicked on this thing here. Then what happens? Take me through the journey. What would expect to happen to the typical patient?
Sure. So the next bit of the journey, the patient will, if they've got back pain, we'll offer them the ability to kind of interact with self-help advice, or we can signpost them to other services. Or if they think they need a GP, we'll then take a history from them about their back pain.
And this can be done on a Sunday morning. So they're at home, they're not queuing on the phone.
Absolutely. Yeah, they can access this any time. But we're asking them a history about their back pain, much in the same way that I would ask, or you would ask a history if you were sat in front of them. So it's a kind of structured history for back pain. Within it are kind of red flags for safety, so that actually if there's a more urgent symptom, it'll pick that up and maybe route them somewhere else. But ultimately what we're trying to do is gather a structured history from the patient about their back pain that we then push through to the practice. And then when the practice is open, they'll pick that up and present it to the doctor, who'll make a decision about what to do with that patient.
One of the advantages over the traditional consultation is that they can say up front, and it gives them a chance to express themselves in their own time and in the convenience of their own home, what it is that they're after, what their expectation is. Surprisingly, even for mental health problems, this can work quite well, so they can go into some detail of how they're feeling and whether they would have a preference for talking therapy or medication, for instance. Another example might be, I'm wondering if I'm anemic. I've got a history of previous anemia. The advantage of receiving that as an e-consult is that you can streamline it a bit and prioritise it a bit, and maybe arrange for them to get a blood test before they come to see you.
And in terms of your workload here, have you, as a stressed GP, found it helpful? Have you noticed a difference?
It's difficult to know exactly where to put it in the working day, and one wouldn't want to necessarily over-prioritise these cases simply because it's a new development and we want it to work. So the timeline of it is we're supposed to get back to them by the end of the next working day.
When do you actually do this? I mean, how do you fit it in?
Well, currently it's the on-call GP, and I would tend to do it in the evening. I might have completed seeing my last emergency patient at that point, maybe done a home visit.
It sounds to me like you like the system, but you're actually having to work quite hard at it. Do you think it's time and resource saving for the practice, or is it a quality issue for the service that you're providing?
It's a bit of both of those. I really like the fact that it smooths out the on-the-day demand. You've got not people crying for appointments on the day or unhappy, I've had to wait weeks and weeks to see you. You've established they need to be seen, and you're establishing a slightly better time frame within which to do that.
Patient feedback is overwhelmingly positive. For the kind of conditions they're consulting for, they like the fact that they could spend some time answering questions in their time. They weren't time pressured. And they may then get a prescription issued or some advice issued without them having to take time off work or time out of a busy life looking after kids, etc., to come into the surgery. So actually patients really welcome this.
And Murray, have you noticed any trends in terms of the sort of conditions that people are inquiring about? Is it different on the system than it would be in face-to-face surgery?
One of the things we certainly find is that patients feel a lot more comfortable consulting this way for certain conditions. So conditions that patients may perceive as embarrassing, things like rectal bleeding or sexual health problems, or even mental health. We get a high proportion of patients who come through with anxiety, depression, because actually they find it a lot easier to express their symptoms and talk about their condition like this. So we're actually picking up conditions earlier, they're presenting earlier, than actually making an appointment and overcoming that barrier of going in physically to see a doctor and pick something up. So actually that's a really interesting facet of this.
However, a concern shared by sceptics is that introducing another gateway into the practice simply encourages more contacts and more work. St Stephen's practice manager, Balvinder Kular.
What we've seen with the data is that just for December, for example, December 2018, we had 1,250 patients contact us via e-consult. Out of those 1,250 contacts, 280 were actually transferred into an e-consult that was delivered to the practice. So e-consult effectively triaged out approximately 1,000 of those contacts by diverting them off to other services. We're not just recycling these patients, they're not then coming through another route. So hopefully it's stabilising our patient demand.
We know from working with lots of practices now, you can close about 70% of those consultations down without calling the patient in. So either with sending them a prescription to the pharmacy and a message to the patient saying go to the pharmacy, or you might call them back just to clarify something on the phone. And about 30% you do have to bring in for a face-to-face, but you can then triage them according to urgency.
Who is using it nationally? Do you have a profile of the typical user?
The biggest age group cohort of users are between the age of 40 and 60, although we've got significant numbers over the age of 65. We've even had 3 users over the age of 100. So catering to the people who use general practice, don't assume just because it's digital it's the young, fit 20 to 40-year-olds, because the reality is those people aren't big users of general practice.
Murray Ellender. More details as ever on the Inside Health page of the Radio 4 website. And because online consultation is being adopted so rapidly in primary care, we'll be keeping a close eye on developments and ongoing research into its impact. Now, every year in the UK, at least 750,000 pregnant women will be screened at their antenatal appointments for preeclampsia, a potentially lethal complication of pregnancy. Telltale clues include high blood pressure, fluid retention and protein in the urine. But how much do women and their partners actually know about the condition? Dr. Manu Vatish from the University of Oxford is part of a team that's developed a new test to help manage women at risk. Yet even his family were not as clued up as you might expect.
So when my wife was pregnant, and she's married to an obstetrician, she said, "What's this preeclampsia thing?" And I sat there and thought, well, if she doesn't know, then what hope is there for anybody else?
What does it actually mean?
Well, eclampsia comes from the Greek, meaning lights or sudden flashing of light, and preeclampsia means before that. And I think the historical reference tells you how long this disease has been in our consciousness, that we're using an ancient Greek word for a disease that still kills a woman every 7 minutes on the planet.
The eclampsia effectively is epileptic type seizures.
So the way the disease works is we know this is a disease caused by the placenta or the afterbirth, and we know that sometimes that placenta doesn't work properly, and that happens in the early part of pregnancy, and then as you move towards the later part, you start to get some symptoms and signs that every pregnant woman goes, why are they dipping my urine? Why are they measuring my blood pressure? And we're looking for high blood pressure, protein in the urine, and we're asking them about certain symptoms and signs that might tell us that eclampsia is about to happen.
So we're looking for preeclampsia, and if we miss it, or even if we pick it up sometimes, the woman might, rarely in the UK, fortunately, progress on to eclampsia.
Yes. So it's seizures, which generally can last several minutes. They represent a fairly impressive threat to the mother's life and to the baby's life. And so we've got lots of remedies to try and reduce that fitting, but our goal is to try and identify that woman before she ever gets there.
Because if we don't pick up preeclampsia, it can lead to seizures and death for the mum. What are the implications for baby?
It means the baby's much smaller than it should be, so it suffers something called intrauterine growth restriction, which is smaller than it should have been. And the other things that can happen to the baby are it's often delivered early is a premature delivery and the complications of that. And occasionally the placenta can actually shear off because the blood pressure is so high, and we call that an abruption, and that's obviously a fairly significant and serious event for the baby.
And how big a problem is it? I mean, every woman is screened for it. How many actually develop some degree of problem with preeclampsia?
In the UK, it's around about 3%. But the problem is we don't know which 3%, so we have to screen 100% to find the 3%.
Have you brushed your teeth yet, Rowan?
Yes.
Or are you going to put a sticker on your chart to show that you have? Good boy.
My name's Ushi Bagger. I've got 2 children and I had preeclampsia in both of my pregnancies. It was all a really big shock. Around kind of 32, 33 weeks, I started getting quite a lot of swelling in my feet and my ankles. And at the time, I just thought that it was probably part of a normal pregnancy symptom. You know, I knew other people that had it, and kind of people were just going, oh yeah, I remember that. So I didn't really think very much of it. And I was going to all my regular antenatal appointments. Every time I went, I'd be asked to do a urine test. But I really had absolutely no idea kind of what the test was for. And then it was when I was 35 weeks and I had a midwife appointment on my way to work. So I just sort of popped in and the midwife took my blood pressure and she was kind of chatting to me and asking how I was. Then I happened to mention that I had a headache and also that I thought that I might need to get my eyes checked or maybe get new contact lenses because my vision wasn't as clear as it had been. And as soon as I said that, I knew that I'd said something out of the ordinary because the midwife's face completely changed. She retook my blood pressure. She explained that she wanted me to be admitted to the antenatal ward at St Thomas's to do some further tests and also to be monitored. And at that point she mentioned preeclampsia.
Good boy.
Certainly being in your first pregnancy is a major risk factor. There's a genetic input, there's an immune input. If you change partners and therefore you've got a new immune environment, that's also a risk factor and equivalent to essentially being in your first pregnancy, even though you've been pregnant before.
Because the baby's genetically different
Yes.
to you, so it presents a challenge
Yes.
to your own immune system. But what's actually going wrong? I mean, when I was training, my professor was quite an old chap and he used to refer to toxemia of pregnancy as if there was some toxin released into the system.
So in some ways your professor was using quite arcane terminology, but in some ways he's actually still quite right. So the disease is really a disease of your vasculature, your blood vessels not working properly. And the abnormality of those blood vessels results in the high blood pressure and it results in the protein in urine and all the other symptoms and signs that we look for. One of the things that toxemia defined was poison. I mean, I suppose the word itself is toxic. And it turns out that actually you've got a change in the balance of factors that are released. So 2 markers that are known to be released by the placenta are involved in blood vessel growth, one of which is helping blood vessels to grow, the other one is stopping blood vessels to grow. And what we see in women with preeclampsia, there's more of the molecules that are stopping blood vessels from growing. And Oxford became the first hospital in the UK to be using that as a diagnostic test. It's a slightly more accurate way than screening people's blood pressure or urine, because your blood pressure can be up for many reasons and you can have protein in your urine for many reasons. And so the biomarker's a bit more specific. And the way the test works is that if the test is negative, it tells us really strongly that the woman hasn't got preeclampsia when we see her and also is unlikely to get preeclampsia for the following 7 days.
And that's important because it affects the management of these women.
If we tell somebody that they've got preeclampsia or we're admitting them because we suspect they have preeclampsia, there's anecdotal evidence from around the UK and many colleagues around the world that women are delivered because there's genuine belief that they've got preeclampsia. That's committed the woman to an operative delivery and it's delivered them of a preterm baby. It then subsequently becomes apparent that the woman didn't have preeclampsia and actually had another condition that was very similar. Anything that can help us to improve our diagnostic ability can only be a good thing. And I will say that in Oxford we are currently undertaking a trial to deplete the circulation of these toxins.
Which involves taking blood from the mother and inverted commas, cleaning it. But what are we taking out then?
It's a protein, the markers that I told you about that we're using as diagnostics, one of which is vastly elevated in women with preeclampsia. We call it soluble FLT1, and the filter we have specifically removes that soluble FLT1.
So you take their blood, filter it and give it back to them effectively?
Yes, we've just done our first patient and extended her pregnancy by several weeks.
Obviously, the aim of the antenatal care is to spot women who are at risk. What happens when you identify someone who's got preeclampsia? How do we treat them?
Well, for the last 2,000 years, the treatment has been pretty standard, which is you watch the woman until you're unable to be sure that she's still safe, and then you deliver her.
I can't do this, I'm not doing it. And we would...
The consultant said that because of the preeclampsia, I'd have to stay in hospital until about 38 weeks when they'd try and induce. And I think the thing that I found hardest was that physically I felt absolutely fine. I didn't feel ill at all, but I was being told that I had this life-threatening condition. I was admitted on the Monday, and on the Friday my waters broke quite suddenly in the middle of the night. Her heartbeat was showing that she was getting distressed. So at that point they decided to do an emergency caesarean. She was 4 weeks early, 4 pounds 10 ounces, so she was quite small.
All the best things come in small packages. Ushi Bagger, and there's a link to the test that Manu Vatish mentioned and more information on preeclampsia on our website. Aspirin may be over 100 years old, but it's still full of surprises. And the latest one is that it may have a role in the treatment of cancer. We've known for some time that aspirin can reduce the likelihood of developing some forms of cancer, but now new research has highlighted a possible role in people who already have the disease. Professor Peter Elwood from Cardiff University led the study.
We put together all the published evidence on aspirin taken by people with cancer. We did a very extensive and careful literature search. We found 71 papers which reported aspirin taking in a wide variety of cancers. We found a reduction in cancer mortality and a reduction in the spread of the cancer within the body. The reduction in mortality was around 20%, which means that at any time after diagnosis, there will be 20% more people who are taking aspirin alive than people who are not taking aspirin. That's a pretty astounding result.
That is remarkable. Do we know how the aspirin might be working?
The mechanisms in reducing the spread of cancer within the body have been very well worked out. And those mechanisms are dependent largely on blood platelets through a reduction in platelet stickiness.
So aspirin reduces platelet stickiness, which in turn reduces the likelihood of spread.
That's right. But the effect on the original cancer itself are complex. There are effects on the growth of the cancer, on the vascularization, the development of new blood vessels enabling the cancer to grow. There are these mechanisms, but obviously there are probably a whole lot of effects of aspirin on mechanisms to do with cancer growth.
Aspirin's long been perceived as a double-edged sword in that there's often a price to pay in terms of side effects for any benefit. What were the downsides identified in your review?
I was disappointed at the way that the media tended to focus on the risks of aspirin. Now, we do not minimise, we do not dismiss the risks of aspirin, but when a patient has been given a diagnosis of cancer, the outcome is depressing indeed. And the risk of a bleed, which we had already shown is most unlikely to be fatal, is trivial. And yet the media across the world seem to focus on the risks rather than the benefit.
Peter, if this was a brand new drug for cancer that reduced mortality by 20%, it would be all over the news.
Exactly. It would get headlines and it would be on the BBC Daily News. Yes.
What sort of cancers did you look at? Was it just the common forms?
We searched the literature and therefore got all cancers. The main cancer, of course, the most common cancer is bowel cancer, and following that, breast cancer and prostate. So our analysis focused on those 3 common cancers, but our main results are based on all the 71 reports of different cancers studied by different teams across the world over the last 30 years.
Professor Janusz Jankowski is consultant gastroenterologist at Morecambe Bay University Hospital and has a special interest in aspirin and cancer.
This really was a unique study showing potential benefit with very little disadvantage in people with advanced disease. We've often referred to aspirin as being almost like a regulator that you would find on a truck, a speed regulator. So that if the truck's going too fast, aspirin generally slows down most of the proliferation responses in the cells. That's the growth responses, so that the cell doesn't grow too fast. But what's unique, if the cell has a mutation, it cannot necessarily die as frequently as it should. All cells die at some point. And what aspirin does is actually, it's a bit like having that truck with a speed regulator, and if you can't regulate the speed of the cells, it almost pulls it into the slow lane gravel pit so that it comes to a stop immediately. So aspirin's got very useful effects. Most cells slows down gently, and for some dangerous cells that harbour very rare mutations, it can kill very effectively.
What sort of research do we need to do, Peter, before we can recommend aspirin as a treatment for cancer?
Well, randomised controlled trials are the gold standard, and it's really a great relief that there are about 6 trials being set up. It'll be 5 or 10 years before those report, and many patients given a diagnosis of cancer will not last to read the results of those trials. But I think the evidence is sufficiently strong to give the patients the choice. They will have a small risk of a bleed, which is most unlikely to be fatal. They've got to be given the choice, and an increase of a year or two's extra survival, I think, should be balanced by patients against the risks.
Janusz, getting a definitive answer is going to take years. What would you say to people with cancer who might want to try aspirin in the meantime?
The most important aspect of this is that there's an awful lot of patients who are on aspirin already. We think somewhere between 15 to 25% of the population at this sort of age group of getting cancer might already be on it. So I think I would want to reassure the patients that they don't need to come off their aspirin unless there's a very good reason to do so. If you're already on it, consider it carefully before you come off it and let your doctor make that decision on your behalf. The second point I would make is that if you consider the risk versus benefit here, the benefits are football-sized and the risks, particularly if you're taking acid-suppressing drugs, are golf ball size, potentially affecting patients' perception of whether they should take it or not.
Professor Janusz Jankowski, and there's a link to Professor Elwood's study on our website. Next week, we explore hospital-related deconditioning. Can a 10-day stay in hospital really age you 10 years? Join me to find out.